It's 3 in the morning. Your patient's blood pressure reads 78/40. The monitor is alarming. The family asks if that's okay. And the resident turns to you and says, "What do you think?" Here's the thing nobody tells you in school. The number itself is the least useful part because the low blood pressure isn't a diagnosis. It's a symptom of exactly one of two things going wrong. And by the end of the next 10 minutes, you'll know which one, just by looking. Let's build it from the ground up. This is lesson 1 of hemodynamics. There's nothing before it, because everything after it, every pressure, every fluid bolus, every "why is this patient crashing?" hangs off this single idea. So we start here. First question. When we say blood pressure, which number actually matters? You chart 78/40. The 78 is systolic, the peak. When the heart squeezes, the 40 is diastolic, the trough, when it relaxes. But your organs aren't perfused at the peak and shut off at the trough. They're perfused by the average pressure across the whole cardiac cycle. And that average has a name, the mean arterial pressure, MAP. Now, the heart spends 1/3 of its time in systole and 2/3 in diastole. So MAP isn't the halfway point. It sits closer to the diastolic. The math: take your diastolic and add 1/3 of the difference between the systolic and the diastolic. That difference, systolic minus diastolic, is your pulse pressure. So for our patient, 78 minus 40 is 38. 1/3 of 38 is about 13. Add that to 40, and you get a MAP of roughly 53. The monitor already calculated it. That's the little number in the parentheses you've been ignoring. A normal MAP runs about 70 to 100. Our patient is at 53. That's the number your patient's kidneys and brain actually feel. Quick check. 2 patients. One is 120/40. The other is 100/70. Pause it. Which one has the higher MAP? The second one. 100/70 gives you a MAP in the low 80s. 120/40, that impressive looking systolic, only gets you into the mid 60s. The bigger top number is the lower mean. Systolic is the number that impresses the family. MAP is the number that perfuses the kidneys. Learn to look at the one in the parentheses first. So, what actually sets that mean pressure? This is where it gets simple, genuinely, mechanically simple. Think of a garden hose. The pressure inside that hose comes from exactly 2 things. 1, how hard the pump pushes water through it. 2, how tight the nozzle is at the end. That's it. Push more water or tighten the nozzle, pressure goes up. Ease off either one, pressure drops. Your circulation is that hose. The pump is your heart, how much blood it moves per minute. We call that cardiac output, CO. The nozzle is your blood vessels, how tightly they're clamped down. We call that systemic vascular resistance, SVR. Pressure equals flow times resistance. MAP equals cardiac output times SVR. And here's why this is the most useful sentence in critical care. If the MAP is low, there are only 2 possible reasons. The pump isn't moving enough blood, low cardiac output, or the nozzle is wide open, low SVR. The vessel is dilated. 2 levers. Every hypertensive patient you will ever have is one of those 2 problems, or both. A patient who's lost volume, or whose heart is failing, that's a pump problem, low output. A patient who's septic or spinal or anaphylactic, those vessels have dilated wide open. Same low MAP on the monitor, completely different lever. And this matters. The pressure number alone can't tell you which. So, your septic patient is warm, flushed, bounding pulses, and hypotensive. Pause. Which lever dropped? the pump or the nozzle? The nozzle, warm and bounding, tells you blood is flowing. The pump's fine, often even cranking harder to compensate. It's the vessels that fell open, SVR crashed, which is exactly why you reach for a vasoconstrictor. You're tightening the nozzle. We'll build that whole story in the vasoactive series. The trap, chasing a prettier systolic while the map rides the floor, or reaching for fluid in a patient whose real problem is a wide open nozzle. Name the failing lever first. The treatment follows the lever. One last piece. How low is too low? Why does everyone chant MAP is 65? Your organs are smart. Over a range of pressures, they autoregulate. They adjust their own vessels to keep their blood flow steady, even as the map moves. Your brain holds steady across a map of roughly 60 to 150. Your kidneys, about 60 to 120. But look at that bottom of the curve. Around 60, autoregulation runs out. Below it, flow falls off a cliff. Organs start starving. That's where 65 comes from. The Surviving Sepsis Guidelines set an initial target map of 65 in septic shock, a floor with a little cushion above the cliff. And a 2026 note worth knowing. For patients 65 and older, the guidance now suggests a target range of 60 to 65 rather than pushing higher. Your facility's protocol is the final word, but that's the reasoning underneath it. But the most important sentence in this lesson, pressure is not perfusion. A MAP of 65 on the monitor with cold mottled skin, a rising lactate, and no urine is not a perfused patient. The number is a proxy. Your assessment is the truth. If an exam hands you a blood pressure and wants a MAP, diastolic plus 1/3 of the pulse pressure, practice it until it's reflex. On your shock patients, set the arterial line alarm to the MAP, not the systolic per your unit's policy. Alarm the number that reflects perfusion. So, the whole lesson in one picture. Blood pressure is a hose. Flow from the pump, resistance at the nozzle. The number that matters is the mean, MAP. Diastolic plus 1/3 of the pulse pressure. When it's low, it's one of two levers, the pump or the nozzle, and 65 is the floor where perfusion lives. But the skin, the lactate, and the urine tell you if you're really there. 3 questions. Say them out loud. 1. Why does MAP track perfusion better than the systolic number? 2. Your patient is 90/60. What's the MAP? 3. A warm, vasodilated septic patient is hypotensive. Which lever failed? And when you hang a pressor, are you fixing flow or resistance? Answers are pinned in the comment. If you got the third one, you're already ahead of where most of us were in our first month. Next on the MAP, we crack open the pump itself, what cardiac output actually is, and the 4 things that change it. That's Hemodynamics 2. I'll see you there.